Welcome, everybody, to the Independent Sage Friday briefing. On Monday, the country entered the first stages of the exit out of lockdown. Pub gardens welcomed people across the land, hair and beauty salons opened their doors, and people could start going back to the gym again. A semblance of normality has returned to us, but at what cost? Have we opened up too early? Do our newfound freedoms put the safety of the public at risk? As Independent Sage has repeatedly warned, coming out of lockdown too quickly, allowing transmission to take off again, makes it more likely that we'll see the virus evolving more, throwing out new mutations, new variants. And despite the success of the vaccination programme, we just cannot afford to be too complacent. Meanwhile, the COVAX programme has taken off, seeking to ensure that developing countries have equal access to the vaccine, the same as rich countries. Independent Sage believes that we're not safe until the whole world is vaccinated, and that this is a global effort and each country should play its part in ensuring vaccine equality. In light of this, we are delighted to announce our support for People's Vaccine, a group that is calling on the UK government to back a patent waiver for COVID-19 vaccines and treatments. People's Vaccine have joined us today. Welcome. We're not having a presentation of the latest figures today, so we're breaking from our usual tradition. And from now on, we'll be presenting those figures on alternate weeks to give us room for more in-depth discussion. So today, we're starting with a Q&A session with the Director of Global Justice Now and People's Vaccine. And I'm now going to hand over to Dr. Tallulah Oni. Tolu.
Thank you, Alice, and we're really honoured today to have two special guests to explore this issue. So as we come out of lockdown, as you mentioned, the importance of vaccine access globally, what the relevance is for the UK, and what needs to happen now and next. So we've got with us Oksana Pijik, who's from the University College London School of Pharmacy, and is a lead of the Global Citizenship Programme and founder of Fight the Fakes, and Nick Dearden, who's Director of Global Justice Now and People's Vaccine. So before we start off, I just want to show this slide to really depict, to center us on the global picture of where we are now. It's very easy as we exit lockdown and increasingly open up to forget and to lose sight of the global picture. And what we see here on the left is the daily new confirmed cases per million people globally, just between September and April. And we can see up until a couple of days ago, and we can see cases globally going increasing across the world. And on the right side, against that, we can see the share of people, so the proportion of the total population in different countries and regions that have received at least one dose of the vaccine. So despite the fact that globally we have this rising cases of COVID, what we can see this huge discrepancy between countries and between regions. So the US covering 35% of its population to date, the continent of Europe at just over 15%, and the rest of the continent, so South America, Asia, and Africa, really paling in comparison. And this really drives home that message of we're not really out of this pandemic until all of us are out of it. And in February earlier this year, the head of the United Nations pointed out that just 10 countries had administered 75% of all vaccinations globally, while 130 countries had not received a single dose. So before we delve into the drivers of this inequality and whether it matters and what it means for us, I thought it'd be helpful for us to understand where things stood before the pandemic with respect to previous outbreaks. So maybe if I can come to you, Oksana, from your perspective from the pharmaceutical and pharmacy perspective, can you share with us your what the precedents for access to medicines and vaccines before this particular pandemic has been globally?
Yes, thank you so much. It's a pleasure to join you today. And when we look at really the precedent for sharing medicines, whether they be vaccines or other products. Although this is not widely discussed, we historically do have examples. So for instance, even during the Second World War, the US government and companies collaborated together to scale up penicillin production. And this was needed to protect soldiers. And companies could have argued against this, putting profit first, but really they did understand the larger picture that losing the war would have a more significant outcome, just like now we are in a pandemic and losing against the virus is going to have more severe outcomes. So at one point, the US produced almost virtually all the penicillin at that time, but there was no, the different companies that were producing this, there wasn't any legal battles. They didn't go in suing one another. But if we fast forward to the 1990s and we think about the HIV/AIDS crisis, and a very different picture emerges at this point when antiretrovirals did become available. They were extremely expensive. And as a result, the South African government, which at that time had a very high burden of disease, over 20% of their population was estimated to be affected. In this instance, we saw that the Pharmaceutical Manufacturing Association actually did try to sue the South African government about when they broke patent laws to try and really create life-saving medicines for their own populations. But they had to back down from this in the end due to the fact that public opinion really turned against them in the sense that it just seemed fundamentally wrong to pursue this path and deny people rights to life-saving medicines. And eventually an agreement was reached through the World Trade Organization with a licensing model that expanded affordable access to patients, particularly within sub-Saharan Africa, which was the most hard hit, and compensating companies for this. So really, those are some examples of where waiving patents doesn't mean necessarily that innovators miss out. If we look at the HIV as an example or wartime model, I think pursuing a status quo as though we were in peacetime could be a mistake. And the final example I would bring up is polio. Many young people won't remember how devastating the effects of polio are or even recognize an iron lung now. But this is a vaccine that was developed first by Salk and without a patent. And he famously coined the term, "Can you patent the sun?" Again, this was viewed as probably the original people's vaccine in terms of ensuring that that public money that went into developing the vaccine was then returned by ensuring that people could get it all over the United States and then broadly the world.
So that's really helpful context, Oksana, just to get a sense that of the power of civil society previously to change and shift social norms, and also that the notion of the people's vaccine is not a new one globally. So if we bring that to the UK and think, why would this be important? Because I guess some people could argue that on one hand, obviously we are in the middle of this pandemic and we have to address our own vaccine access. And on the other hand, we've been donating to the schemes, the COVAX scheme, which we'll hear a bit more about later. So why is this relevant from in your opinion to the UK, and what is it that we need to be doing differently?
Yes, so the UK is one of the largest donors towards COVAX. That is the arm in terms of donating vaccines to low and middle income countries, but that's only really geared towards 20% of the population. It's not enough to really reach herd immunity in those regions. And in terms of self-interest, if we look at the UK and what's going on globally, you just showed a picture that shows a really troubling trend. We know that the UK situation is improving, but the trajectory is heading in the wrong direction globally. And we've had 7 weeks of consecutive increase in cases and numbers, 4 weeks of increasing deaths. So this we should be paying close attention to. We've already heard a lot about variants of concern and how that could undermine the current success of our vaccine rollout and the newfound freedoms that we are currently enjoying. So if we only focus in the UK, we do neglect to think about what's going on with the threat of variants. But equally, when we think about, I think most people are under the assumption that all manufacturers are working night and day to produce as many vaccines as possible. But again, some of the restrictions around the creation of vaccines, so the legal framework around that actually means that some of the major vaccine producers are sitting on the sidelines here and not contributing to that effort. And I do think that we need to shift in a mentality, because we are living through an exceptional period in history where flexibility in trade regulations do actually need to be applied. This isn't we shouldn't be using the same model for that favors innovation as we do in peacetime. Certainly that does have its merits and its benefits, but there are times where competition needs to be set aside for the greater good. And again, looking at the UK, it'll only be a matter of time before the problem circles back to us. So the donation is great, but it doesn't actually lead to jabs in arms because we're not using all of our manufacturing power across the world.
So I want to tease out 2 points of what you've raised there. So the first is around the why. So one aspect that we teased out was the equity dimension, just because it's the right thing to do, and it's not, there's an injustice about having a small proportion of the world having access to the vaccine, or to a vaccine in the middle of a pandemic. And then the other point you raise is just actually self-interest, and actually it's in our best interests to ensure vaccine access globally as the quickest way for us out of this lockdown. Is that right? Are those the two key things?
Yes, and I hate to use this, really, the war metaphors have come on so frequently. But if we think about it this way, we have vaccines as our best tool, and these are our best weapons, and we've only given them to a portion of the world, and 0.2% of low-income countries now have vaccines. So you think about this in terms of, it is us, the human race, against this virus. We haven't really put ourselves in a position that favors our species. What we're doing is we're creating a circumstance where 80% of the most populated regions in the world have very little access to vaccines, where they're rising, as we just saw the charts that you showed, cases. So we are creating conditions that favor the virus, and we're not, if you again want to say, arming ourselves appropriately for the front lines where they need to be.
Thanks so much, Oksana, for setting that scene. I'm going to hand over to Anthony at this point, just so that we can have some time left for you to comment on Nick's input and vice versa. But I think it's really important, in handing over to Anthony now, to explore a little bit in more detail the how and what's behind the call of a patent waiver, and exploring these notions of charity versus justice, if you like, as two aspects of addressing this inequality. So over to you, Anthony.
Thanks very much, Tolu and Oksana. And as you've emphasised, this is not an issue of aid and charity. It is about the science and self-interest of, because we're all in this together. And yesterday there was a letter from 175 former leaders, Gordon Brown, Francois Hollande, Mikhail Gorbachev, and a whole lot of Nobel Prize winners, all saying they wanted a patent waiver. And we've got Nick Dearden here, who's from Global Justice Now, People's Vaccine Movement. Why can we not do this with we've heard about COVAX and CTAP. Isn't that enough to solve this problem? Why do you think we need a patent waiver?
Well, COVAX was a really great idea. I mean, let's try to ensure that the distribution of coronavirus vaccines around the world is as fair as possible. The problem is most rich countries simply bypassed it. I mean, they bought all the vaccines that were on the market. So we now have a very small amount of countries sitting on, the vast majority of the world's vaccines. So, absolutely, COVAX needs money and so on to buy its vaccines and ensure that these vaccines can be distributed. But at the moment, there really aren't the vaccines on the market. And any more money that we put in risks simply ending up in the pockets of the big pharmaceutical corporations, who in many ways are keeping those vaccines off the global market because they've sold them all to rich countries. And that was also kind of foreseen by the World Health Organization, which is why they set up this other body called CTAP, which is the Coronavirus Technology Access Pool. And the idea of this was a place where all of the scientific technology, know-how, and patents themselves could be pooled, so we could learn and collaborate, we could make better vaccines, and we could share them as much as possible with manufacturers around the world. The problem with that is all of the companies that own the patents, that have been handed the patents by governments like the British government, have essentially boycotted CTAP. So it has no know-how, it has no scientific knowledge, it has no patents to pull. And that's really, really shocking. And it's one of the key reasons, as Oksana said, why manufacturers around the world, factories around the world are lying idle, unable to produce these vaccines because they don't own the property and they can't get hold of the know-how. And that even includes factories in Europe, it includes factories in the Indian subcontinent, factories across sub-Saharan Africa who aren't producing. And if this is a warlike effort, like Oksana said, that's absolutely ludicrous to have factories that simply cannot produce the vaccines we so desperately need.
Yeah, so I mean, this is a fight, if you like, between competition and collaboration. And there was a meeting this week in the African Union to discuss their own manufacturing capacity and how it could be upgraded. And I was astonished to find that actually Nigeria, South Africa, Kenya, Tunisia, Morocco, Algeria, Senegal, and Egypt all make vaccines. They just don't have the technology for this, and they don't have the patents. It seems like a no-brainer. Are the philanthropists of the world not aware of this and keen to share patents, or do they still get behind a market mechanism to try and solve this problem?
I think that's exactly the problem, that essentially many of the people driving global health policy, like the Gates Foundation and so on, have a kind of inherent belief in the market. That the market will solve all of our problems and that patents are an important aspect of that. But what we've seen time and time again is that really isn't the case. So my organization, for example, has been working on these issues for long before we knew about coronavirus, because it was pretty clear to us that the pharmaceutical system was already badly broken. Now, someone like Gates will argue, well, you need patents because vaccines and other drugs are really expensive to produce, and therefore a company's not going to produce them unless they can guarantee a revenue return from them for the long term. That really isn't how the system has worked at all. In fact, the intellectual property system, which was agreed at the World Trade Organization in the mid-90s and kind of imposed on the whole world with these very long monopolies, very long patents, have actually disincentivized research and development. So what you now find is many of the companies involved in vaccine production, or any kind of drug production actually tend to, their R&D budgets tend to be absolutely dwarfed by the amount of money they're spending on mergers and acquisitions, on litigation to protect their patents, on lobbying to extend their patents. And where there is R&D, it tends to be pushed towards treatment, not cure, but treatment of chronic conditions that tend to be suffered by rich patients or patients in rich countries. And what you find is the real life-saving stuff that we need, like the coronavirus vaccines, have to therefore be supported by public money. A huge amount of public money has gone into coronavirus vaccines. In my opinion, we have then, as society, done the absolutely crazy thing of simply privatizing that research, handing it over to big corporations who then decide who gets vaccines and who doesn't get vaccines. And it's a crazy system because we could have put conditions on the money that we put in the first place to say, we're not going to patent this. You know, if you're a private company and you're contributing to this effort, then fine, you can be paid for that. But for goodness sake, don't incentivize those companies with a 20-year monopoly on something that they haven't actually invented in many cases in the first place.
Yeah. So the Pfizer-Moderna vaccines are much more expensive than AstraZeneca. So AstraZeneca is the one. So if you look at Africa, I was looking at some of the figures. So there are 1.4 billion people in Africa. So they're going to need about 800 million people vaccinated, which means between 1.5 and 2 billion doses. And at the moment, their aim is to get 60% covered by next year, June next year. So in a year's time, they're not aiming even for this year. They've only had 7 million doses so far, and they're already running out because the deal they have with AstraZeneca in India's production has been blocked now because India is saying we need these vaccines. So there's this real vaccine nationalism going on. And there's a big price difference, even with AstraZeneca, which is supposed to be not for profit. I believe it's $2 a shot in India, $5 a shot in South Africa, and $7 per shot in Uganda. But the mRNA vaccines are much more expensive than that. If you look at the number of doses that Africa's hoping to get, they're hoping to have 75 million in another few weeks' time. At the moment, they've only had 300,000 of Pfizer because presumably it's too expensive. Why is there this price variation?
Well, it's a really good question, and the fact is we don't know the answer to it because so much of the contract system that dictates what companies can charge is secret. We all know about the dispute that's going on between Britain and the European Union over the contracts with AstraZeneca. One of the key problems is just a lack of transparency, and so AstraZeneca obviously licensed its product, or the Oxford vaccine, to the Serum Institute in India, and the Serum Institute then seems to be charging, like you say, South Africa twice what it charged, what AstraZeneca charged the European Union, and then there was this story about Uganda being charged 3 times as much, and we simply don't know why, but it definitely makes us question the extent of the non-profit commitments of some of the companies who have made those commitments. Of course, it's a good thing that they're trying to distribute this vaccine without profit, and there are differences between the companies there. But at the end of the day, this is a vaccine that the whole world needs as cheaply as possible, as fast as possible, and the market mechanism, the monopoly mechanism that is how vaccines are currently owned and distributed around the world simply doesn't work for the situation that we find ourselves in now. I would also say, when we look at the non-profit commitments that AstraZeneca have made, as I say, good insofar as they go. But there was a piece of research done this week that found that of the R&D that went into the Oxford AstraZeneca vaccine, 97 to 99% came from public and charitable sources. AstraZeneca was also then given at least $2 billion for trials and to ramp up manufacturing. So, I'm not saying AstraZeneca's done nothing, but it didn't produce this vaccine. It didn't create this vaccine. And therefore, it really shouldn't be in its gift to decide who gets it and who doesn't get it. And it really shouldn't have a monopoly that it will absolutely profit on in the long term.
Yeah, it's interesting. Dr. Tedros from WHO said, if you can't waiver a patent for this one vaccine now, then when can you ever? Are we locked into this kind of market mechanism, which simply doesn't work? I mean, if it worked, fine. I don't mind whether it's private or public sector, as long as everybody gets a vaccine. I remember, I'm old enough to remember that a boy in the year above me at primary school had paralytic polio. I was in the first generation. I think I must have got vaccinated when I was about 5 or 6. And, that was because of sharing of the patent. Oksana quoted, was it Jonas Salk? And we expect it was a public good. And I think nations have to take back control of this and say this is a public good. But my final question is, I think you were saying yesterday, Nick, or the other day, that Jim O'Neill was saying something, the ex-Goldman Sachs economist, that the big pharma model is kind of broken for antimicrobial resistance and antibiotics. So my final question is, how can we address this in future? And what's going to happen with the next pandemic? Are we going to be back in this position? Or do you think there'll be such public pressure on the private sector that they will have to come up with a solution that's much more equitable and rapid?
I think that's exactly...
Nick,
oh, sorry.
Before you jump into that question, actually, because I think it would be good to end on that question, and I kind of want to ask both you and Oksana, because you've gone into a lot of detail around the IP and the explanation so far. It seems quite a bit of a no-brainer. So if I can just ask you both very quickly first, before we come on to that last question, maybe Oksana first, what would be the good faith argument against an IP waiver? So if it's so obvious that it's something that's needed, what would be the good faith arguments against it?
Well, I mean, I think what we need to consider is that the environment we are in now, and with the current model that we've been following, and there's arguments to say that it is there are problems with it even before coronavirus. But for those who are perhaps have a different view on this, then and would want to incentivize innovation, despite the fact that there is a strong public input in it, then okay. But during a pandemic, we need to look at this. We cannot keep enforcing the status quo as a business model. Every other sector has changed. We have had to change how we work. Healthcare workers have had to change how they work. There's no part of society that has not had to make some kind of adjustment. Why are we saying in this capacity, business as usual? I just, in this, I'm struggling to see where we can really enforce something that perhaps outside of wartime pandemics, et cetera, has a place by letting the market lead with some conditions. But this definitely is the time for reform.
I think that's a good point. And then maybe to Nick now, there is a context of the pandemic, which is obviously an exceptional situation, but there's also the reality that you have both outlined, that the system was already broken to start off with going into the pandemic. So recognizing that we have all of these other health emergencies and threats coming up, what would be needed? And, if you can combine your answer of thinking about the good faith argument against with what your counter to that, if you like.
So yeah, I mean, as Oksana says, I mean, one of the justifications for the system is that you need monopolies in order to generate a return on R&D. As I say, we dispute that because we actually believe that most of the really essential R&D in the world actually comes from the public sector. In fact, the more risky and the more essential the R&D is, it's the more money the public sector puts in, which is exactly what you've seen with coronavirus. And indeed, I just brought along a very short quote from Senator Wyden, who runs a committee in Congress that looks into these issues, and he had a whole range of pharmaceutical companies coming before his committee, and he said, after seeing all the evidence, look, drug makers say changes in the status quo will hurt R&D, but a quick look at these companies' finances on both sides of the balance sheet shows it just isn't the case. Revenue generated from American patients alone dwarfs what they spend in R&D worldwide, and I think that problem, it isn't just about coronavirus, as important as it is for us to get this awful virus under control. I mean, just look at antibiotics, on which so much of our medical system relies, in which there have been an absolute paucity of research into new antibiotics for decades now. But why? Because big pharmaceutical companies did not see any profit motive in inventing new antibiotics, because they knew they would be second or third wave antibiotics and they simply wouldn't generate any return for them. So they haven't invented this medicine, which is so important for everything we know about healthcare, would make certain operations almost impossible without them. And it's that was actually prompting Jim O'Neill, formerly of Goldman Sachs, to say, look, this system is just broken. It's not fit for purpose, and actually, you need to nationalize certain bits of the operations of pharmaceutical companies if you want to have a healthy world. And he was sitting on the Tory benches at the time in the House of Lords, so not necessarily someone you would expect to come up with this kind of argument. But I think that's a sign of just how serious the problems are that we face, and how little I think the current model benefits the world at large and creating a healthy society. And we absolutely think governments have got to put conditions on the research money they put in, but there are also lots of other ways of incentivizing the private sector if that's what you want to do. I mean, we think you should also create public manufacturing and public research and development that can be shared around the world. But to the extent that you want to put the private sector to be involved, you can offer them payment for the services. You can offer them prizes that's been suggested in a kind of medical pool model for the work they do. There's lots and lots of other ways to do this, other than simply say you have a very long monopoly on this drug.
Thank you very much. I'm going to move it on now.
Yes, that's going to head back to you.
Thanks, Tolly. And that's a brilliant overview, I think, of where we are with vaccinations and the moral, but also the rational and scientific case for global equality when it comes to vaccines. We've got lots of people waiting with their questions, so I'm going to go straight now to Chris McLaughlin from the Sunday People. Chris, are you with us?
I am. Can you hear me?
Yes, I can. So, and we all can. So, go ahead.
Two questions, if I may. One on the theme that we've just been discussing. What is it that the speakers would like to see the UK government or governments do? What's the answer? What needs sorting? What mechanism should be in place?
So we'll take that question first. And if you've got a very short supplementary question, I might let you ask that.
Well, it's on a different subject. It's on a different subject.
Okay.
Okay.
Yeah, let's deal with this one first then. So,
okay.
I mean, we were talking about patents. So is that the answer? Is that we just make those patents available?
Let's go to be released.
Yeah, let's go to the panel then.
Should be put in their place.
Okay, thank you. So who would like to start with that? Oksana, have you got a comment here? Yeah.
Well, first, the UK is opposing the IP waiver of the TRIPS agreement that has been put forward by South Africa and India. So to start, the government could support this temporary, I think that's also a concession here, a temporary waiver. Alongside, now that's not going to solve everything. We also need to ensure that we have develop pharmaceutical capacity outside of where it already exists. So in low and middle income countries, there are pockets that Anthony has highlighted, but we could do more to ensure that medicines are being manufactured where they are needed in the most populous regions. And that will require investment. So we have to be looking at what we can do in the short term, the medium term, and the long term. If we're looking at the long term, certainly building up pharmaceutical industry within LMICs and supporting that is the long term. Because then when we look towards what will occur when the next pandemic occurs, there are more sites ready to go. It's not all monopolized in a few. So practically, there is the WTO has met already this week in terms of negotiating what they can do to support scaling up of making these vaccines, because the variant is all about us outpacing it by vaccinating. And the slower it takes us to vaccinate, the more likely that eventually we could be in a situation with a vaccine-resistant variant. So if we wait till 2024 for other populations to receive vaccines, again, we've already highlighted what that threat could mean for the UK. But there are two practical things that I think we can do today, and something that has a longer vision on developing that pharmaceutical manufacturing capacity.
Thank you.
You're on mute, Alice.
Thank you. Anybody else on the panel want to comment here? I mean, we talked about nationalisation, but is there an argument for internationalisation, and how would that work?
Yeah,
Who would like to pick that up? Nick.
I think that's definitely true. I mean, so much R&D is already in public hands that actually, and we know from the NHS and the way that some medical research works in this country, that it's better to collaborate on this kind of stuff. I mean, look at Pfizer's vaccine, which needs to be stored at very, very cold temperatures. Moderna has used the same technology to make one that needs to be stored at less cold temperatures, and there's a possibility that it will improve, and that will mean it's a more useful vaccine in other parts of the world. But we've got to learn from each other. I mean, it's ridiculous that this stuff is all kept secret. And so different companies and the public sector can't learn from each other. So I think that's so that collaborative model is absolutely essential. And I think it's being trialed in small ways for some HIV and AIDS medication. Oksana might know more about than me. But an absolute prerequisite for that is the suspension of the TRIPS agreement as far as it relates to COVID, vaccines, drugs, and other equipment. We absolutely need that, and it's really shocking that Britain has bought so many more vaccines than it needs. I know it doesn't have them at this moment, but it will have over the course of this year, so many more than it needs. And then it's telling the countries that have come to the WTO to argue for this suspension, really, there's no problem. the market will deal with your problems in the long term. I mean, it's just awful. And every rich country is in that position, with the notable exception of Vatican City at the moment. So we absolutely must push our governments to unblock that knowledge. But as Oksana said, that's not all. We then need to ensure that the technical know-how is shared, and we need to begin building manufacturing capacity all the way around the world, because if there's one thing this pandemic has shown us, it's that the vast majority of the world cannot rely on simply getting vaccines and other drugs exported to them from a small handful of countries. And that's the other thing the intellectual property system's done. It's concentrated the production of all sorts of medicines and drugs in a small part of the world. And what we need for security is a much more networked and distributed system of manufacturing around the world.
Thank you very much, Nick. Anthony would like to comment on this question too. Anthony.
This is part of a much broader issue, isn't it? Since nation states were formed really in the sort of 17th century, the state had the right to raise taxes if they provided security to their people. So there's this trade-off between tax and security. Now, if we're paying our taxes, but our governments are completely overawed by private sector, we saw it in Facebook in Australia when they switched off all the services. We've seen it with all the, the fear of government to take on these massive corporations. And this is a perfect example. I mean, this is a global threat to all of us. We've all paid our taxes. That tax money has been invested in the vaccines. And yet it's now being hijacked by a few corporate interests. And if that's allowed to continue, it threatens the whole stability of the world in other ways as well, because people will say, well, why are we paying all this money when we have no control?
Thank you, Anthony. Professor Gabriel Scally, you have an opinion too.
Inevitably, Alice. I just wanted to make one point, and that's about the creation of the UK Health Security Agency, and what that really means. That's the replacement for Public Health England. When you look at what they've said in terms of that agency of government, it is very much seen as working towards the success of UK PLC. And it is also seen very much as being part of the medical industrial complex of the country. So I do think that there are fundamental issues about the nature of health and healthcare in the UK. And this challenge about the UK's attitude on vaccine is an absolutely central issue to that at this time. We either go one or two directions, and we either accept that the UK and the NHS are part of this market-driven complex, and that aid money, like NHS money, is just simply feeding the needs of the medical industrial complex, or we actually say, no, this is for the good of humanity. It's good for the good of people in the UK and humanity. So I'm absolutely 100% behind this campaign. I think it's so important, not just for dealing with COVID, but for setting a tone for how we're going to conduct ourselves in the health and public health arenas in the coming years.
Thank you very much, Gabriel. And now on to Stephen Reischer, Professor Stephen Reischer.
I have a question for Nick, because listening, I think anybody listening, I think everybody listening to Oksana and Nick will be, quite outraged by what's going on. I mean, the fact that public money is used to generate private profits to create a vaccine that's too expensive for most of the world to use it is an obscenity. And I think the fact that our government, the UK government, is actively blocking the most obvious solution by protecting patents is equally quite outrageous. And I think anybody hearing it would be outraged and want to do something about it. So the question is that when we say trying to get the UK government to change its attitude, I'd be interested to hear what are the things that Global Justice Now is doing? What are your campaigning activities, and how can we support them?
Thank you. Yes, so I mean, it's a mix of our normal campaign activities, really, writing as many emails as we can to politicians, putting pressure on through the media, trying to make the case by hearing from the voices of those who need the vaccine and can't get it at the moment. And really, I have to say, I'm so impressed that people are so on side in general, including in rich countries where we have a lot of vaccines. There was an opinion poll done in the United States just yesterday that found that over 60% of the American public believe in waiving vaccines, 75% of Democratic voters. In this country, we've done similar opinion polls, about 3/4 of the country support it. So absolutely, it is about how we turn that latent public opinion into something a bit more active that the government really can't ignore. At the moment, an awful lot of time is being spent trying to persuade and convince the Biden administration, because they seem, interestingly, like the one most ready to listen to some of these arguments. And I think that's potentially not just because they see this is absolutely vital for getting the economy going again. Like you say, we can't just open up a bit over here and expect everything's going to be fine while other countries are suffering the ravages of coronavirus. So I think they want that, but I also think they're getting nervous, actually, that they're going to start losing out in the vaccine diplomacy stakes to the likes of China and Russia, who are creating their own vaccines. So there's a bit of self-interest there as well, which might help push them over the edge on this one and actually do what's so necessary. But I mean, I just think this session today is so great. I mean, it's really helping us get the message out, and the more we can do this kind of stuff, the more people can talk to people in workplaces, colleges, places of faith, whatever it is. We've seen big campaigns like this in the past over trade rules, and we've won. You know, we heard about the South Africa case a little bit earlier on. It is possible, even though it feels like we're all the odds are against us, it is possible to win. And I think we've just made such a great start on this work. I'm so impressed with the 175 world leaders, but many of whom I have serious disagreements with, but who've all come together to say we support this. That's really, really powerful. And so I do think we're getting somewhere.
Thank you very much. Chris, I'm afraid I'm going to hold your supplementary question because that one developed in such an interesting direction. If you stay with us, and if we do get through everybody else's questions, I will come back to you. Thank you.
Right,
we're moving on now. Thank you very much. We're moving on now to another question from Charles Gaskell. Charles.
Hello. The UK policy has been to vaccinate people in descending order of vulnerability. And we've now got through the top 9 tiers of the most vulnerable. Is there a point when the UK should stop vaccinating those people that are even less vulnerable than those, and instead donate their remaining doses of vaccine to countries which have higher numbers of highly vulnerable? And if that's the case, where do you draw that line? What's that point?
Thank you very much, Charles. Who would like to start with that question? How do we manage our own vaccine program? How do we start to? I mean, obviously, we're already investing in COVAX. Gabriel.
Well, funnily enough, I was just thinking about that issue, Charles. If I was asked, I've had 1 dose of my vaccine, and if I was asked, do you want the 2nd dose, or would you prefer it to be given to someone really vulnerable and elderly in another country that doesn't have vaccines? I would say yes, do that. Personally speaking, what I think is what I think is the possible thing to get widespread consensus in UK society on is that we immediately say that we are not going to hold these contracts for 3 times or twice the amount of vaccine we need, and we immediately commit to donate all the surplus right now. And that's something I think we could get very widespread political support for. And I think, irrespective of where you draw the line, and we could argue forever about where you draw the line, that is something that could be done now. It could be done today. And the issue also of stopping of the support for the waiver could be done today. So let's concentrate on things that we can do. And that's one where we've got surplus vaccine on order and we don't need it.
Thank you, Gabriel. And Professor Deenan Pillay, you'd like to answer this too.
Yeah, thanks. And just to contribute to this discussion and maybe also get Nick and Oksana's view on this. As Gabriel says, the country has ordered whatever 3 times, put in orders for 3 or 4 times the total population being vaccinated. Now, I can understand in the early phases of vaccine development why that strategy it mitigates against vaccines going down in clinical trials, and we're seeing this all the time. We've seen this about vaccines that have not worked and have fallen at various stages. So whilst I completely agree with Gabriel that given that we that we have got potentially excess vaccines coming our way, and that there should be therefore that should be used to distribute elsewhere. My question is, in the context of the sort of development process and the risky, and of course, if pharma was sitting around here, they'd say, well, there is a risk to our investment, and that would be their argument in favor of patents and so forth, because of course, vaccines can fail as well as succeed. Is what is the way that we can start to consider in this rapid development phase, and that with the uncertainty, how does one actually then plan for vaccine access around the world? So answering to some extent, but also coming up with questions that others can contribute to.
And Professor Christina Pargle, you'd like to contribute?
Yeah, so it's in terms of whether we donate our vaccines to other countries. I mean, the issue is supply. And it seems pretty convincing to me from what Nick and Oksana were saying, that the best way of addressing the supply issue is to drop the patent. And then you can manufacture a lot more.
With respect,
aren't doing it now. So to me, that's what we should be trying to lobby the government to do, to support dropping the patent and allowing more vaccine to be produced and distributed.
With respect, though, that's not really the point of my question. My question was more to do with whether we aim to vaccinate 100% of the population, whether they're vulnerable or not, or whether we say vaccinate those 70%, 80% that are most vulnerable, and donate the vaccines that were earmarked for the other 20%, rather than anything to do with getting rid of suspending patents or increasing production or anything like that. This is something which we already have. We have this vaccines paid for on order at current levels of production.
Yeah. Okay, Charles. I think Kit Yates is very keen to jump in here. So, Dr. Kit Yates.
So I'll partly answer that. I think there's a strong argument for vaccinating as many people in the country as possible. Speaking as a younger unvaccinated person, I don't want to get COVID. I don't want to get long COVID. I also think that vaccinating as many people as possible reduces the possibility of transmission, and it also reduces the possibility of allowing new variants to evolve in a situation where we have a partially vaccinated population, which means they can potentially have a selective advantage. So there are lots of reasons for continuing to vaccinate our own population. I think one of the answers to that problem is to think about relaxing patents so that we can upscale vaccination production and not have to make that choice between, do we vaccinate a whole of our population, or do we try and vaccinate other countries in the world? So I think this actually does, this talk that we're having today does actually answer that question to some degree.
Can I just say, have I misunderstood it? But I thought there was at least 3 times as many vaccines in the UK as we need, even if we vaccinate our whole population. So isn't the answer, we vaccinate the whole population, but we right now give away 2/3 of the vaccination supplies that we have, in addition to the patent argument. So we don't have to have a choice between who do we vaccinate and not vaccinate versus contributing the majority of what we have to other countries in the world.
Thank you, Susan. And Professor Stephen Reicher wants to come in now as well.
So, I mean, just as it's true that we're not safe until the world is safe, it's equally true that the world isn't safe until we're safe. If we allow infections to rage, then we can reinfect people elsewhere in the world. And actually, if you look at the balance sheet of variants, we've done more harm by exporting the so-called Kent variant to other countries than we have been harmed in many ways. And it's absolutely essential at a global level that we too take infection suppression seriously, that we get everybody vaccinated so that we do play our part. And when people talk about going to other countries, we often talk as if the problem is that people will get infected elsewhere and bring variants here. Again, the problem lies the other way around, people going from this country. So being good global citizens means, on the one hand, supporting everyone in the world getting vaccinated, and secondly, taking our responsibilities seriously and driving infections down. So I don't see those two as counterposed. I see them as going together. And additionally, I mean, absolutely what Gabriel says makes sense. We might want to make personal choices. But also, Susan's point, there's so much that we don't need. Yes, that should be exported, but it shouldn't be counterposed to the vital responsibility to drive infections down in this country.
Thank you very much, Stephen, and everyone else. I'm moving on now to our next question. It comes in from John Swinburne. John, are you with us?
Yes. Can you hear me?
Yes, you can. Go ahead.
Oh, that's nice. Afternoon from a sunny but very cold Scotland. Deceptive, a bit like Big Pharma. Oxford aimed to produce the vaccine between no cost at all and 7 pence until Gates intervened. AstraZeneca declared profits of an increase of $1 billion, including a 15 million bonus for CEO Pascal Soriot. So it's not a bad return for R&D costs, which you pay 2% of. Western nations, reported in the Sunday Observer, said at WTO that waiving patent rights would take too long. Now, I'm confused about this. Can somebody explain to me why waiving patent rights would take too long? It's very curious to me. Also, big lobbying. Lobbying, is it easier now that big business can purchase civil servants to work for them while they're still in office, allegedly in public office? And a technical question. Small study, AstraZeneca, South African variant, minimal protection. Does that mean 50% efficacy and 100% protection against hospitalization or deaths? Or is it something different from that?
Oh, John, you managed to fold 3 questions into one there.
I'm so sorry.
That's all right. Let's start with the first one. How quickly can you waive a patent? Does anybody know the answer to that? It seems to be an argument against waiving patents, but I mean, how quickly can it be done?
I think Nick will answer that.
Yeah, I mean, you can make the decision really quickly. And then it's about how removing the international power to enforce those patents. The more difficult thing might be getting the pharmaceutical companies to share the technological know-how for how you actually manufacture this stuff.
Exactly.
And of course, that's got to be part of the process too. There's no question about it. But again, it is going to be much, much easier to do that without the patent system in place. And you could make a decision about that quickly. India and South Africa brought this to the WTO, I think back in October or even November, right? Yeah. So it has been held in discussions with richer countries, continually pushing back and saying, well, we need you to prove the case before we can make any progress. This has been going on months. And that's ridiculous because, think about, I know it can take a very long time to gear up a factory to produce a certain vaccine, but actually often not as long as you might think. So the mRNA vaccine that Moderna's making in Geneva, is being made by a company which has no previous experience of making such vaccines, and they geared up in 4 or 5 months. That's 4 or 5 months that this issue's been hanging around in the WTO. We're just wasting time now.
So quicker than you'd think is the answer to that then. Anthony, you wanted to comment here?
I think Oksana should go first, actually.
Oksana.
Yes, in terms of the decision making, that part is it isn't so complicated, and the shortages of supplies, etc. We have to. These are artificial. They're artificially created by these agreements that we, as people who our governments are meant to respond to, we absolutely can advocate for a people's vaccine. One of the arguments you'll hear is that it'll take time to train people, to retrofit certain labs. Okay, but we still need, again, we need medium, short-term, long-term actions to be taken. So take them. And if that means we're better off in the future, let's work on that today. I don't think that any of those arguments actually have any meat to them. And it's been repeated over decades over, this idea about innovation. But, innovation has been part of human history before patents even existed. So again, this is about protecting profits. Also, globally, the G20 has spent over $10 trillion dealing with the fallout of this pandemic. So when we think about the cost to our economies, again, some of the Nobel laureates were economists who signed this letter supporting the people's vaccine. They also argue there is an economic case here for us, for all societies to be able to return towards generating greater profit. So we can't just put the one industry's interests above all the others. If anything, we should be looking at other industries to also say this is costing them by protecting their profits.
Thank you very much, Oksana. I think the second question was quite rhetorical, so I'm going to pass on to the third one, which was about variants escaping vaccines. And I wonder if anybody on the panel, yes, I thought Deanan might want to answer that one. Deanan.
Well, John, just with regard to your last question, about it's true, as you say, that a small study in South Africa demonstrated that the AstraZeneca vaccine was not really effective at preventing mild to moderate disease. There was no severe disease in that cohort, and of course that remains the big question, because it doesn't mean that AZ cannot prevent serious disease and death with that South African variant, but it does illustrate, and so I wouldn't, even with the potential for the so-called South African variant to circulate within the UK, I don't think the evidence is there at this moment to say we shouldn't be using the AZ vaccine. But it does. Just bringing this back to the global discussion, it does raise an issue when I look at South Africa, of course, which has hosted two big waves and potentially a third one, in that they had negotiated for AZ vaccine to be produced and imported from the Serum Institute, India. That they negotiated at a high price for some reason. There's a lot of debate within South Africa about that. Of course, in addition, the Serum Institute is now constrained about the degree to which they will export vaccines, because the requirements of the Indian government to deal with its own pandemic. But at the same time, South Africa decided then, on the basis of the results we just talked about, to not roll out AstraZeneca vaccine anyway and put all its eggs in the Johnson & Johnson basket. But of course, as we're speaking, the J&J are starting to prevaricate about the rollout of their own vaccine. That's their own self-imposed limitation based on the potential for blood clots. So that's left South Africa in a real difficulty at the moment, and just demonstrates the complexity there is, which is generated as well by some of the patent issue, as well as, of course, the real safety issues that we learn about as vaccines are rolled out outside of clinical trials.
Thank you very much, Dean, and thank you, John, for your questions. And now we're going to go to a question from Dharmendra Patel. Dharmendra.
Yes, good afternoon. My question relates to COVID variants, which are vaccine resistant. We see a large number of COVID cases in places like India and Europe. But do we know which variants are dominant there? Is there much genomic sequencing? And is there a risk of a fresh wave in the UK from one of these variants?
I'd like to start with Dharmendra's question. Deanan, can you give your perspective on this?
I'll certainly. I mean, everyone now is a virologist and their views on variants. But Dharmendra, thanks for that comment. Indeed, there are variants that are developing, and I think we need to go back to first principles as well. In that, as long as there is ongoing transmission of this virus, variants will develop. And I think it's the very first slide that Tolu showed, which is basically global levels of infection now are as high as they've ever been. You know, this is and those number of infections are going up. Even though in the UK we're seeing a reduction, globally they're going up, and therefore as long as those infections are going up, there is the potential for new variants to develop. Each of those variants, clearly, as soon as they arise, are assessed when they're found. They are assessed for the ability to escape natural infection and natural antibodies, or antibodies to natural infection, or indeed vaccines. And they vary a little bit with regard to that. But the point you make about the coverage of genetic surveillance is of course critical. That the UK is perhaps the biggest provider of genetic data to the global databases, and yet still within the UK, it's only maybe 10% of viruses over the period of the pandemic that have had their genomes sequenced. And of course, that varies very much around the world. And the fact that we call variants, for instance, South African variant, is not because they started in South Africa, it's because South Africa has the capacity to genetically characterize and sequence these. It doesn't mean that that's where it started. Equally with Brazil, there's sequencing capacity in Brazil. That doesn't necessarily mean that that's the Brazilian variant. And in fact, we should really slap ourselves on the wrist for talking about the Kent variant, South African variant, Brazilian variant, because these are global variants that have emerged somewhere and are spreading, and we're only see what we find. So I do think that genetic surveillance needs to be seriously strengthened, not only for this pandemic, for future. But my final comment is with regard to the concern that these will escape vaccines. My sense is that any immunity is better than no immunity. And of course, we've got to remember that this is we're just over a year into this pandemic in a naive population. In other words, around the world, it's not like flu, where we've had many decades and millennia of circulation and ability then for antibodies to develop, which lead to some level of cross resistance, even to cross protection to even other variants. Here we've had a year of a completely naive human population seeing the virus. And I think as vaccines are rolled out and natural infection and antibodies develop and maybe T cells, then there will be some level of protection against subsequent variants of the virus. That's not to be complacent, but I don't think we should be too fatalistic about this at this stage.
Thank you, Dean. And I think that was a really comprehensive answer. So unless anyone is desperate to chip in at this point, I'm going to move on. I can't see anybody desperate. Thank you very much for that question, Dharmendra. I'm moving on now to Helen Dawson. Helen, are you with us? Sounds
Hello.
like she is. Hello.
So as you said at the start, Alice, restrictions are easy, but it's really hard to gauge what's sensible to do at this point in the pandemic versus what we're allowed to do. At every point up till now, our family's done less than we were allowed to, as we didn't want to catch the virus or spread it to our relatives or indeed anyone else's relatives. So my question for the panel is, please could you talk about what you personally will or won't be doing in the next month, and whether it makes a difference if you're vaccinated versus not vaccinated?
Thank you very much, Helen. It's those tricky transitional times, isn't it? When we've got used to one way of life and then life is changing. And who better to talk about that than Professor Susan Mickey? Susan.
Well, I'm sure there's many people who are better than me talking about it, but I'll start the answer. I think we have to now move from this rules-based approach to a risk assessment and risk management approach. But that means us learning much more about what does risky mean, and what are the settings, what are the types of event, what are the types of activities that are more or less risky. And I hope that the government will shift from that, because we can't remember all the hundreds of rules that keep changing anyway. And we're in this for the long term. So we need to begin thinking in that way. And there are some very basic principles. I mean, a key one for the coming months is outdoors is so much more safe than indoors. It's something like 1/20 of the number of transmissions, and certainly of the super spreader events, happen outdoors compared to indoors. Hardly any transmission happens outdoors. The other thing is, if you are indoors with anybody else from another household, keep it ventilated, get windows open, doors open. And just bear in mind how the virus works in terms of finding a way of getting from one person to another. So the fewer people that you meet up with in the smaller numbers for less long time, the more you keep a distance from them. And even small things, for example, if you're out in the pub garden, which I'm sure we all want to get out to, try not to sit face to face with people, sit at a 45 degrees angle. So just for people to remember that this is aerosol, you know, we have moved in our evidence to realizing that it's primarily aerosol driven. So it's really what comes out of your mouth. And you just need to think that it goes out of your mouth, the trajectory of it, even tiny aerosols will go in a particular direction. But also remembering that indoors, these aerosols can hang around for many, many hours. So I think it's those kind of principles that should govern what we choose to do and not choose to do. And also to be thinking about making places safe, especially workplaces. Anybody who's going back into a workplace, make sure it's been inspected, make sure you get the information about it being safe. And in relation to your question about vaccination, people do let down their guard and behave more riskily. And what we see in both here and also similar data in Israel is that the infection rate goes up after 8 or 9 days as the people, well, the interpretation is that people are behaving in a more risky way and before immunity set in because of the vaccination. So I think we need to bear that in mind, that vaccinations are only partly protective.
Tolly.
Yes, I want to try to answer a bit of your question, Helen, about personal, what we would personally do. So I'm going to stick my neck out a little bit there and say, in addition to Susan's point around risk assessment, for me as a public health physician, I also think about the population level effectiveness of different control interventions, right? So at the individual level, there's the vaccination when you're eligible, there's the PPE that you can wear. And as you go further up beyond the individual, they become more effective at a collective level. So things around the numbers of people, things around engineering controls. So how safe places are, Susan mentioned the workplace, but also retail environments, hospitality. So for me personally, I remain more cautious than the rules, not because of vaccination status, but I would be so much more comfortable if I knew that these engineering controls, so if there were measures in place and we say, okay, if you go into hairdressers, if you go into indoor spaces, this is the standard. And this is what is being enforced in terms of ventilation, in terms of individual level behavioral measures. So I think it really highlights the importance of beyond the individual, the importance of that environmental legislation and enforcement of that to feel safer, if you like, and to be safer at a population level.
Thank you very much, Tolly. And yes, to ask questions as well, because I think it's really been brought home to me that there's so much variation in what different industries are doing. Working in the broadcast industry, where we got up to speed pretty quickly in working in a COVID secure way. It's never completely COVID secure. But then I contrast that with the situation in schools, where there's very little being done in terms of ventilation and social distancing even. Zubaida, can I ask you for your opinion on this?
Well, I'm going to come at it from a different angle, Helen, which is that despite what Boris Johnson is saying, the country is not at the same level of COVID cases throughout the country. There's a huge difference between deprived and non-deprived areas in terms of the levels of cases that are still circulating, in terms of the hospital admissions, and in terms of the deaths from COVID. And we know that slightly poorer areas and urban areas still have slightly worrying high levels of cases. So it's much more precarious there. And of course, at the same time, we know that in some of these areas, there's lower rates of vaccination, including in London, where we have also more variants circulating. We just heard this week that there's more surge testing in Lambeth, in Wandsworth, in Southwark, and in was it Barking? No, Barnet, and in Barnet. So we've got more variants, we've got slightly less vaccination rates, and we've got higher cases in deprived areas. And we know in deprived areas there's higher levels of minority ethnic groups who are 2 times more likely to die with COVID, especially Bangladeshi and Pakistani groups. So we have to think about it in that context as well, that if we are living in those areas, we've got to be even more careful. Because, I mean, we've been talking about it today. It's not just about us. It's also about our social responsibility to everybody, but also that we are only as safe as the most vulnerable. Thank you.
Thank you, Zubaida. And Gabriel, I think you wanted to comment as well.
It's a very good question, Helen. I've just been sitting here thinking about it. I mean, personally, I was trying to think of the things that I've done differently. I've met with 1 or 2 family members in the garden. I've had 2 of our postgraduate students who are doing public health in Bristol round for lunch in the garden because they're here from India doing this course, and it's great to see them personally, having been teaching them for the last few months online. I've been swimming in the outdoor swimming pool in Clifton, which I really like, and that's good. But I've already decided some of the things I'm not going to do. I'm not going to go and watch London Irish play Wasps at the end of the Premiership season, but not because I worry about being outdoors in the stadium, but getting there. I would really want to go up on the train and maybe go on the tube to get there. So I don't think I'm prepared to do that. So it is a very interesting thing. And a bit as some of my colleagues were saying, I feel completely differently now going into a shop, and I look around to see how many people are there. I look to see, is there any sign of any ventilation in this shop at all? And I think just gradually over the next period of time, we're going to see a lot of that change as more and more people have learned quite correctly. As someone said, the virus is spread by aerosol, it's spread in the air. And unfortunately, some of the messaging is still really quite misleading, both from WHO and indeed from the government. Talking about droplet spread, we should be thinking absolutely air spread and acting accordingly. So very
Gabriel,
interesting. Thank you.
Gabriel, would you go to the pub? And if so, who would carry you home?
I wouldn't go to the pub, and much as I would love to, and I certainly wouldn't be singing in the pub, which would be my normal form of activity in the pub. But I do have very good online sessions with of Irish music and singing as well. So I'm well looked after. Thank you very much, Anthony, for your concern.
And how about you, Steve?
Well, in things I'd like to do, I mean, I've actually never met any of the people on Independent Sage. I've seen them every week, several times. Many of them, perhaps not all of them, but most of them feel like friends, but I've never met them. So the one thing I'm looking forward to is meeting these people, seeing what they're actually like if you actually meet them face to face. It's probably a daunting prospect. Perhaps I'll be deeply disillusioned, but that's what I'm looking forward to. I just wanted to make a couple of points, though, which I think are critical. Last night, I was asked exactly the same question on the Scottish News, because today, for the first time in Scotland, you can travel. Scotland's opened up a bit more quickly. And there were all these terribly moving vox pops of people saying, I haven't seen my family for months. I haven't seen my friends for months. I haven't seen my grandchildren ever, because they were born a year ago and they live outside the area. And what was implicit in those things was the remarkable heroism of those people who hadn't traveled, who hadn't seen their family, who had abided by the rules. And the most important thing to realize, the most important message to take from what's happening now, is that this is happening because of people's remarkable adherence. We are here because of the ways in which we have behaved. We are here because of all those sacrifices. But that cuts both ways, of course, because if we suddenly forget things now, think things are all over and behave without restraint, then we can go backwards. So I think the fact that our behavior matters, I think, is the most important message. And the second point I want to make, and it picks up on what Tola was saying, is yes, it's individual, but individual behavior is dependent upon the worlds we live in and it's dependent upon the nature of the environment. And even if we know what the hazards are in principle, we can't deal with those hazards unless we have information. And there are a number of initiatives in different countries I think we should be learning from. So, for instance, if we're talking about going out to particular spaces, we need to know what spaces are safe and what ones aren't safe, what workplaces are properly distanced, what pubs and hospitalities meet COVID standards. If you look on the website of Pennsylvania, the state, you will find that you can look up every bar and every restaurant in your neighborhood and find out whether it meets COVID standards and has been certified as such. You know what's safe and isn't safe. If you go to New York and look on their website, you can find out about every classroom in every school, how good the ventilation is. And again, that information is critical for people, first to push for more safety, but secondly, to know where things are safe. So yes, it's up to us and our behavior makes a difference, but our behavior needs to be supported and scaffolded by what institutions do and what the government does. And I wish the government was doing more to help us keep ourselves safe.
Thank you very much, Steve. Thank you, everybody. I'm going to draw the discussion to a close for today. We've gone from individual behaviour, individual responsibilities to global responsibilities over the course of this discussion. And I'd like to lift one quote from today, and I hope I'm quoting it correctly, and it's this from Stephen Reicher. The fact that public money is used to generate private income for companies to make a vaccine that much of the world cannot afford is something that most people would find outrageous. I want to thank our special guests today, Oksana Pizik and Nick Dearden, for helping us look at that global picture and the case, not just a moral case, but a rational scientific case for vaccine equality. Thank you to all our contributors for your questions today. And thank you to everyone watching, whether you're watching us live or catching up. And thank you to the scientists of Independent Sage. Everyone here is a volunteer. They make time for this because they believe that dialogue between scientists and the public is crucial, especially in a time of pandemic. It's important for them to be able to share data, analysis, and scientific opinion, but it's also important that scientists are listening closely to the public and understanding a diversity of experiences and concerns, whether those are personal, national, or indeed global. All of Independent Sage's reports on all sorts of aspects of the virus and the pandemic are there on the website. And please follow us on Twitter if you don't already. And we're on Instagram too, with the handle @IndependentSage. What else? We'll be back same time, same place next Friday. Stay home if you can. Stay safe. Keep well. Thank you, everyone.
Bye.
Thank you.
Bye.